surgery. I'll begin my talk first, which is on congenital eyelid colobomas.
I'll interrupt Dr. Grover just for a minute, just to give his introduction. Though we all know him, he is an internationally acclaimed oculoplastic surgeon, a wonderful teacher. We all have learned from him and his presentation over the years. And he is a recipient of Padma Shri and many other awards. So, and of course, he is the chief instructor of this particular course. So thanks a lot, Dr. Grover, sir, for giving all of us this opportunity. And we all look forward for your presentation on lid coloboma. Please, sir.
Thank you, Mukesh. It's the affection of you and all the entire oculoplastic committee and community which keeps us going and striving for our best for the patients. Thank you, Mukesh. So I'll be speaking on congenital eyelid colobomas. This is a subject I started to love when I was starting my oculoplastic services in 1984 in the Maulana Azad Medical College. And since then, saw a number of cases to the extent that we had published in 2005. I think we had published 51 cases. It was the largest series in the world till then. Congenital colobomas of the eyelids have been described over 5 centuries ago and may be the result of abnormal migration of ectoderm and mesodermal tissues of the face. However, mechanical disruption of eyelid development by amniotic bands or various facial clefts may also be responsible. These colobomas imply either partial or total absence of eyelid structures. More often, the upper lid is involved, and in that case, medial third is usually affected, but almost 1/3 cases are involving the lower eyelid. These may be unilateral or bilateral. The systemic associations are that it may be a part of a first arch syndrome, first branchial arch development anomaly, and Gordon-Haas syndrome and Treacher-Collins syndrome constitute this syndrome. Associations with facial clefts of various types are also common, most commonly 310 and 411. Gordon-Haas syndrome was the commonest association that we had been seeing. Presence of limbal dermoids, temporal dermolipomas, upper lid colobomas, unilateral or bilateral, preauricular tags, and vertebral anomalies constituted the Gordon-Haas syndrome. Treacher-Collins with lower lid involvement as notches in the lower lid was the second commonest association. But as we said, facial clefts were common, and Fraser syndrome was another common association. We look at our observations later. There are a number of other associations that are known. So now we're presenting the data of our 65 cases, which is the largest reported so far. This was the publication in 2009 in Journal of Pediatric Ophthalmology and Strabismus. So we find that males and females are almost equally affected. They may present early or they may present very late. Upper eyelid is involved in 2/3 of the cases, lower eyelid in 1/3. Gordon-Haas syndrome in about 20% of the cases in our series, and Treacher-Collins and facial clefts in about 10% each. The commonest presentation in the upper lid is as a unilateral involvement, and bilateral constitutes only about 15 to 20% of the cases. All of them are located medially, supromedially, and the size may vary from a small notch to huge size, almost involving 3/4 of the lid. Most often they are unilateral, 35 or 43 in our series, and these are usually benign with no exposure keratopathy. Exposure keratopathy is relatively less common in these cases, constituting only about 6 of 35. And some of them rarely have an absent superior fornix, something which is much commoner in the bilateral group, as we will see. In the bilateral colobomas, exposure keratopathy is the rule rather than the exception, and absent superior fornix with skin of eyelid running onto cornea is the commonest presentation in 6 of the 8 cases, constituting a symblepharon variant of cryptophthalmos, and association with Fraser syndrome should be looked for. Bilaterality cases, 2 of them were small notches and not associated with any exposure keratopathy. Management of these cases starts with medical management, but most cases would require surgery. The surgical management is immediate when there are large defects, especially with those with absent superior fornix and with exposure keratopathy. But in those where the defect is small and there is no exposure, it may be deferred for 3 years or more. And the surgical management is decided on the size of the defect. Attempt is primarily to try and do a direct closure or canthotomy closure with tensors so that pupillary axis occlusion can be avoided. But those who already have a pre-existing extensive corneal involvement, or those who are operated late, can be repaired by slit shearing techniques. Let's look at how we did these repairs. In these upper lid colobomas with exposure keratopathy, because the cornea was already involved, we could do lid shearing procedures in 11 of them. But in 7, we did tensors. 14 of these 18 had absent superior fornix, and we had to create a superior fornix using a mucous membrane graft mostly. But since we find that this hypertrophy is a great deal in children, now as the amniotic membrane grafts have become more easily available, we are often preferring amniotic membrane grafts. Those without exposure keratopathy can more often be smaller and be repaired by direct or tensors techniques. Lower lid colobomas may be again unilateral or bilateral. Unilateral ones are usually medial associated with clefts, and bilateral ones are usually those with Treacher-Collins syndrome, smaller and in the lateral part. So bilateral ones are with Treacher-Collins, and they are usually a small notch. Lower lid colobomas are largely with facial clefts and one with a rare choanal atresia and bilateral orbito-oral cleft. The repair is usually by direct repair in the smaller ones, but in other cases, a more complex repair may be needed where the defect is larger and there are other abnormalities. So this is an example of a direct repair here where the notch has been corrected. There was a bilateral ptosis as well, so we did a bilateral fascia lata sling at the same time. Examples of tensils repair, we'll skip the video, and closure by tensils technique. The tissues have less give. You need more laxity to be created on the outer side, but results can be gratifying. Although, as we see, notches are more likely in these than in older subjects. A Cutler beard procedure where pre-existing opacity is quite significant or the child is older can be done. An example in a small child here with exposure keratopathy with repair. An example of difficulties involved is this one case of repair where there was a 2-week infant with bilateral upper lid colobomas with absent superior fornices with severe exposure keratopathy with an appearance like this with no vision, presenting very early. We did a dissection of the superior skin, created a fornix with a mucous membrane graft, as you can see here, and then took a tarsoconjunctival flap for repair of the internal lamina. Skin could be mobilized as it was excessive and taken from that which was present on the cornea. So this is the stage 1, and this is after tarsoconjunctival flap was released. And we could get a good reconstruction, although symblepharon does tend to occur very often in these children because of excessive reaction. And we could get rid of the exposure, keratopathy, and vision could improve significantly. Example of a lower lid notch which has been repaired here. And this is the unusual medial lower lid coloboma with choanal atresia and facial cleft. Here we did a lateral canthotony catholysis, mobilized the medial canthus, and we then did a direct repair in this area and did a deep medial canthal insertion. And we could get a reasonable repair in this patient. So surgical results are functionally gratifying with, we have very long follow-ups. The problems include notches, wound dehiscence, or recurrence of symblepharon. So to summarize, the special considerations in surgery are that there is a poor lid laxity, particularly if you have to operate them young. In younger children, occlusion of visual axis should be avoided, and mucous membrane grafts show excess proliferation, consider AMG. So congenital colobomas with their widely varied presentations are an extremely challenging problem, but can be managed satisfactorily in most cases. Thank you.